Okay, continuing on chapter 21 with the different ways that poisons actually enter into the body. So absorbed and surface contact poisons, they can affect the patient in several different ways. The most important ones would be interaction with skin, mucous membranes, and eye damages, chemical burns, rashes or lesions, and then even though they're only coming in through some small area, they can still have systemic effect on your patient. So make sure that you distinguish between contact burns, where it's pretty much going to stay right there in that localized area, be it the skin, maybe just underneath, or did whatever they get exposed to actually absorb into the body and have a bigger chance of causing systemic type effects. Signs and symptoms include just them telling you that they've been exposed to whatever it is, some sort of liquid or powder on the patient's skin, burns, itching, irritation, redness of the skin, and then some substances have a pretty typical odor associated with them. Doesn't mean you'll always pick it up, but if there is something that the National Registry throws out as a specific odor, then they're going to have that go to a specific substance, just for testing purposes, FYI. Emergency treatment for a contact poisoning includes, first and foremost, try not to contaminate yourself or those around you. Remove the substance as rapidly as possible. This could be simply brushing off a dry material, rinsing off a wet material, etc. Remove all contaminated clothing, even if you're not 100% sure that it's been contaminated. Better to be safe than sorry. If a dry powder has spilled onto the patient, brush off whatever is left of the powder, and then you want to flood with water for 15 to 20 minutes and then wash it with soap and water after that. And then if it's a liquid, you don't have to do the whole brush off portion of it, but flood for 15 to 20 minutes. So it's saying flood. The true term for that is irrigate. You're going to irrigate that for 15 to 20 minutes. If a chemical agent has gotten into the eyes, it really doesn't matter what form it's in, but you're going to irrigate the eyes very, very quickly and very, very thoroughly, because it can cause some pretty crazy damage if you don't. What you're seeing here in the picture is they actually have a nasal cannula hooked up to IV solution, and it's draining down and going out both of the nasal prongs, which have been placed on either side of the eye. Whenever we flush an eye, we want to go from medial over to lateral. If you go lateral into medial, if both eyes aren't contaminated, you have the possibility of accidentally having some spill over your nose and contaminating the other eye. So if we go from the medial aspect out to the lateral aspect, then all it's going to do is run down past the ear and onto the floor. And yes, it's not comfortable, but it is necessary for helping that patient. So just kind of try and talk them through it. Oftentimes you're going to come in contact with this type of toxin in an industrial setting, and there are specific protocols for those areas that they have to have in place in order to have those chemicals on hand. Oftentimes there's a safety shower, or they have just specific protocols for handling some sort of exposure. They should have their own hazmat team that should be available to assist, and they may not be like this highly trained hazmat team like the fire department, but they have been trained enough that they can be pretty valuable to you. We're going to make sure that us as providers, our team, and then the patient are thoroughly decontaminated. We don't want to take a contaminated patient into the hospital. Nobody is going to thank you for that, ever. So make sure that you decontaminate them. It's one thing to take an ambulance out of service to clean it up because it didn't quite get decontaminated enough, it's another to take an entire ED, hospital, etc. out of service for decontamination. If at all possible, um, try and obtain material safety data sheets on whatever the patient's been exposed to and transport them with the patient if for some reason they don't have them readily available. And part of the protocol of being able to have that substance on their site is that they have to have these. But if for some reason they don't have them, they can fax them into the hospital later. About 80% of all poisoning is going to be through ingestion. Um, when talking about age groups, if you're talking about children, it's usually accidental. But once you start getting up into those teenage years where you should truly know better than to put some random substance in your mouth, it's more deliberate, truthfully. And the signs and symptoms are going to vary greatly depending on what you took, the age and weight of the patient, and then how long has it been since you ingested the substance. Some of the common signs and symptoms include burns or rashes around the mouth, gastrointestinal pain, nausea, vomiting, cardiac dysrhythmias, and seizures. Try and treat what you can for signs and symptoms, and then contact poison control or medical control. They're going to give you the best course of action for how to treat the patient. If the patient has an altered mental status, we're going to spend a good portion of our time protecting the airway and making sure that that patient doesn't vomit and then aspirate. You want to try and consider if there's any unabsorbed poison still left in the GI tract, and there might be an opportunity for us to prevent that absorption. Some EMS systems allow EMTs to administer activated charcoal. That's definitely a medication that's kind of falling out of favor right now. I've given it several times, but I know that protocols are starting to shift to not be as excited about activated charcoal as they used to be. If your system allows you to administer activated charcoal, make sure you know when you should give it and when you shouldn't. There are some medications that you will never ever give activated charcoal with. Bottom line, ABCs are still going to be your focus, and then move on to anything else. Injected poisons, this can be IV drug abusers, or they got bit by something or stung by something, so insects, arachnids, aka spiders, or reptiles. Injected poisons get into the body very, very, very quickly. They can either cause a systemic reaction, or they can just cause a pretty intense local tissue reaction. You can't dilute them or remove them from the body in the field. The whole, we used to cut open snake bites and suck the poison, we don't do that anymore. Nope. The patient's condition can go downhill very, very, very quickly. So make sure that you're not playing around with somebody that's been injected by something. Signs and symptoms include weakness, dizziness, fever, chills, unresponsiveness, or they might be overly excited about what's going on. Like anything else, we're going to monitor the airway, provide high flow O2, and keep a sharp eye for nausea and vomiting. Try and remove any rings, watches, bracelets from the area around the injection site, especially if swelling is starting to occur, because we don't want to have to cut those things off if we don't have to. For the patient assessment, the scene size up, a well-trained dispatcher can obtain a lot of that information that you're going to need pertaining to a poisoning call before you even get there. Any sort of proper protection that you're going to need when you enter the room, information pertaining to the mechanism of injury or nature of illness, number of patients that are involved, whether a trauma is involved. Those are kind of standard things that your dispatch should be able to collect for you. It's when you get there that you're going to have to look for those additional clues to figure out what's going on. So is there an odor in the room? If there is, are you sure that the scene is safe? Are there medication bottles laying around? If so, is there medication that's missing? And yes, we have stopped to count pills to make sure that the correct amount was missing or to determine if there were extra missing. Are there alcohol containers present? Oftentimes when somebody's going to take an illicit drug, um, you know, drugs and alcohol go very well together for some people. And so oftentimes it's not just that they were partaking in the illegal substance. A lot of times they'll throw some alcohol on top of it as well, just making it that much harder to take care of them. Are there syringes or other drug paraphernalia on scene? First and foremost, trying to make sure that those are safe so that nobody accidentally gets a needle stick. Your safety is key. And then, is there a suspicious odor or drug paraphernalia present that may indicate the presence of a drug lab? If you're not just somewhere where they're using the drugs, but somewhere that they're making the drugs, that's your chances of being exposed just went through the roof. People that make meth, they actually, when you buy a house, you have to sign a paper right now saying that you have never made meth in the house. And if it's determined that meth was created in the house, they, in order to completely mitigate that substance, they have to remove all wallpaper, all carpeting. They have to repaint the entire house with a sealant. Um, Oftentimes you have to decontaminate basically every surface in the house, as well as, I want to say, the first top 2 feet of topsoil need to be removed and replaced in order to make sure that there is nothing in that house that could continue to poison people as they come in. For your primary assessment, get a general impression just like with anybody else. You want to assess your level of consciousness, determine any life threats, and certainly don't assume that a conscious, alert, and oriented patient is stable. They can very quickly go downhill. Airway and breathing. If the patient's having difficulty breathing, make sure that you give them some oxygen. Have your suctioning available, especially with somebody that has ingested the toxin. The likelihood of them vomiting is very, very high. For circulation, assess your pulse and skin condition just like you would with anything else. Your transport decision. We want to try and get patients that have been exposed to a toxic substance into the hospital very, very quickly after being appropriately decontaminated. There's not a whole lot that we're going to be able to do for somebody out in the field that has been exposed to a toxic substance, so we have to get them to higher definitive care. History taking, you want to obtain their medical history. This can be performed en route if necessary. Start with sample. If the patient is unable to tell you things, being either unresponsive or just not knowing what's going on, make sure that you try and get that information from everybody else around them. Additional questions: what substance was involved? When were they exposed? Do you know how much? Have any interventions been performed, and then how much does a patient weigh? And we talked about that earlier as well. For your secondary assessment, honestly, we may not have time to perform a secondary assessment. If we get the patient decontaminated and in the rig, we should be moving pretty quickly. If you have to, for your physical exams, focused on the area of the body that was involved with the poisoning or was the route of the exposure. Once the ABCs have been managed, conduct a thorough physical exam just to make sure that you didn't miss some substance somewhere. And then make sure that you take a complete set of baseline vitals. Many poisons aren't going to produce really any noticeable outward signs that are going to indicate how serious that exposure was. If they have alterations in level of consciousness, pulse, respirations, blood pressure, and skin, that's going to give you more of an indicator of how they're doing and how much they took. So make sure you get that set of baseline so you can watch for trends. We'll continue in the next one.